We are on a mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast, you'll get actionable business advice.
Hear stories from industry leaders,
And share a laugh or two with us.
Fuel your passion for pharmacy.
one conversation at a time.
4,
3,
2,
1. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I'm your host, Jeff Key, president of PioneerRx, and today I'm here with my co-host, Marsha.
Hi, I'm Marsha Bivins. I'm the Director of Marketing for PioneerRx. Today our guest is Tony Minniti. He is the owner of Bell Pharmacy in Camden, New Jersey. Tony, welcome.
Well, I don't know that we've met, Tony. Jeff Key, have we met?
I don't think so.
I'm older and don't, but I usually remember faces.
Yes, small space.
Small space.
Small memory space.
Yeah, okay.
I harass him about that all the time.
Yeah, my statement I say when I can't remember something is that when your room is really full, it's harder to find things, right? And she says it's a little room, so
Must be a small room.
it must be a small room. We both remember different things, so I think your brain prioritized to remember things that probably you prioritize, but
I find that I'm forgetting things more and more these days.
yeah, or just it takes a little bit longer to retrieve. But you can imagine that picture of a room, right, that is just full of stuff, and if it's not on top, right, it just takes a little bit longer to get to, right? You know about where it is, and eventually you get to it.
Sounds like an episode of Hoarders.
An episode of Hoarders. Yes. And this is Marsha Bivins.
Hi,
Marsha Bivins, our marketing director.
Hi, Marsha.
Hi, nice to meet you, Tony.
So just tell us, let's just start off with a little bit of personal stuff. How did you get in pharmacy?
I actually started working for my grandfather when I was 14 years old at his pharmacy, Dog and Arrows in Camden.
Okay.
And I've never done anything than work in pharmacies in Camden ever since. And I'm 52 years old now. So that gives you an idea of how long I've been in the profession and also in the city.
So lay out, where is Camden in New Jersey and in relationship to like New York and that other stuff?
Camden's right across the river from Philadelphia. If you want to compare it to something, it would be like Hoboken to New York City.
Okay.
Or Red Bank. We're just, we're right across the river.
And is it, how many people? What's the population of Camden, New Jersey like?
Population somewhere around 85,000.
Okay. So smaller town?
It's smaller, yes.
Nice.
Yes.
There are some very pretty parts of New Jersey. And then, of course, there's some very city parts of New Jersey that I'm driving through, that have been driven through there in the past.
Yeah, we have a fascinating dynamic here because in New Jersey, you have, we'll take Camden, for instance. It's probably one of the most impoverished cities in the nation.
Really?
And 9 miles down, you'll have Morristown and Cinnaminson that are two of the most affluent. And then it's quite a mix you have, all in a very small area. And then there's other parts of Jersey where you go out and it's almost like being in Georgia. But that's down in the south part of it.
Yeah. So you started off 14 working in your grandfather's pharmacy. So I assume your grandfather was a pharmacist. Does that mean was your dad a pharmacist?
No, this is on my mother's side.
Okay.
Okay.
My father's a chef, as is my brother. They're in the far more attractive fields, I guess.
Oh, so they're a chef.
Everybody loves chefs,
So that's cool.
Yeah,
So both
Chefs.
parents were chefs, right? Your medicine is a chef, right?
In a way, yes.
Kind of compounding.
You're
You're building creatively, and being a chef could be compounding.
Well, in many ways, when you work in a kitchen, you got to learn how to manage high volume with accuracy and delivering a quality product. And that really trained me well for doing what I do in retail pharmacy, because a lot of the operational dynamics are very similar, believe it or not.
And didn't somebody release a book about the science of cooking? They spent a lot of time researching and stuff about really more science.
Yes.
Piece.
I think it's legitimately called The Science of Cooking.
Oh yeah, okay. Look at that. Must have been sitting on top. All right, so grandfather had a pharmacy.
So do you own that pharmacy now, or is it still in, I guess, is it still one that you own or you're a part of, or have you opened your own? And
well, it's an interesting story. The way it went, when I graduated Philadelphia College of Pharmacy in 1993, I bought into my grandfather's business. It was a family business. And then my sister, who graduated subsequently in the year 2000, she then bought into the business. In 1997, we purchased Bell Pharmacy, which is where I am now. And in 2013, due to retirements and just differing ideas about business, the family, some people stayed at Dagonero's Pharmacy, and my sister and I took over things at Bell Pharmacy. So that's where we've been ever since.
All right. So over this time, from being 14 to being in your 50s in pharmacy, what's the most profound thing you've learned? If you had to boil it all down to one,
what stands out the most?
Give us the wisdom of the ages.
One of my professors at the time, who's very prominent now, his name is Dr. Cal Knowlton.
Dr. Cal. We know Cal.
Yep.
I had him for the practice of pharmacy back in 1992. I actually did, interesting story, one project was either to start a pharmacy from scratch or to buy an existing pharmacy through a purchase. I'd made Bell Pharmacy my project. I got an A. And Cal wrote a personal note on thing. It still rings to me today that he said, "Watch out, Camden. Here comes Tony Minniti."
Nice.
But Cal spoke at that time about a post-dispensing future for pharmacy. And now in 1992, that was mind-blowing. I mean, I looked at it as we dispense prescriptions. That's how we get paid. That's how we make money.
Right.
And Cal always spoke about pharmacists as practitioners and robotics taking over dispensing and all these different concepts that pharmacists would be able to start practicing more towards the top of their degree. And seeing that transition occur over time has really been something to see. And a lot of what Cal spoke about back then assisted us in positioning ourselves for where we are now, which is really a post-dispensing future.
Very cool. Do you keep in touch with Cal? Any of the stuff he's doing?
Yes, every once in a while we happen to do a similar forum together, or I'll shoot him a quick note. Cal's a very busy guy, tabula rasa, and he's got a lot going on, but the nicest, most down-to-earth man I've ever met.
Very, very true. Very accurate. So you offer a lot of services in your pharmacy. Tell us about those.
Well, we started getting into, different areas by getting creative. New Jersey has what's called a collaborative practice agreement that we're allowed to do that allows pharmacists to almost act as dispensers as long as it's subsequent to some agreement that's approved by the Board of Pharmacy and maybe sometimes by the Board of Medical Examiners. We started off initially years ago. Our first foray into this was with Narcan. Before Narcan became the thing, we saw that it was, when the opioid crisis was really full blown in Camden and what was happening, we discussed this idea of Narcan. We got together with a physician, formed a collaborative agreement, and we were so aggressive in the marketing, I would say, or I should say the marketing probably isn't the right word, but the counseling and the promotion of Narcan to initially, it was just our opioid patients who were on it long term, but quickly we revised that model to make it a mandatory. Every time a patient came in with any opiate, we approached them to discuss Narcan and to recommend that they get it. Of course, New Jersey was very quick to have that covered by all insurance companies. And one of the interesting things that we ran into is, someone comes in, an older person, let's say with Tylenol with codeine from some sort of procedure, and we would recommend Narcan. The first reaction would be, well, I'm not a drug addict. Why would I need that? And we always likened it to keeping Ipecac or an EpiPen on hand. I said, I don't foresee this being a problem for you. I said, look, you can take one and then maybe take too many if you get groggy and you don't remember. I said, or worse, if you have a child in the house that actually consumes the Tylenol with codeine you have the ability to, provide a sort of rescue dose of Narcan while the EMTs arrive, and seconds matter in these situations. And it was so well received that eventually the state itself incorporated this idea of every time an opiate prescription is issued, pharmacists are required to counsel and offer Narcan. So that was our first foray into more getting creative and utilizing that ability to have those agreements.
So how did they find out you were doing that?
Well, we're sort of active on social media, and we have a lot of interaction with the Department of Health. They asked me about it, and next thing you know, there it was. A memo came out from the Attorney General's office, and they issued a standing order for all pharmacists. We had to register with the state, but whereas we went and we formed our own collaborative agreement with another physician, now any pharmacist was able to have a similar agreement, but by getting it with the Department of Health and through the Attorney General versus going out and doing it all on their own. So
that's extremely progressive. I mean, there must have been a crazy opioid abuser stat that helped push that into place for New Jersey.
And we have a very challenging population in Camden. We're at the nexus of so many different healthcare issues, and it was much of what we did with Narcan that kind of brought us into our next idea was, the issue and access to PrEP, Truvada for PrEP, Descovy. You're seeing more about it now. But I looked at prescription of PrEP very much like I did the prescription of Narcan. Really, if you're taking Truvada or Descovy, you can really only use it for one thing. And at the time, I had a housemate who was a gay man, and he asked me about this idea of PrEP. This is somewhere around 2015. I had never heard of it.
Wow.
I said, he goes, well, I looked it up and I said, well, it's Truvada. I said, it's been around for a while, but usually that's just used to treat HIV. And he's like, no, I'm hearing more about this. It's supposed to prevent HIV. So when I did the research into it, it was like, wow. It does. They had trials in Africa over 2010, 2012 that showed these phenomenal results, but it was failing to get traction here in the United States. I can never understand why. But I looked at this coming up in that era in the late 80s and early 90s. If you tested HIV positive, it was a terminal diagnosis. I mean, you were going to die of AIDS eventually. And there was so much focus on let's find a vaccine, and we never really quite got there. And I the question I said to myself, I said, how could they have something that prevents transmission of HIV by upwards of 98, 99%? And this would have been hailed as a miracle in 1992, and it's gone completely under. So we've tried to work with different infectious disease specialists to try to form that collaborative agreement where we would be able to prescribe Truvada, now Descovy for PrEP on site in the pharmacy, and we came up with a pretty creative model where you were able to do the entire visit and initiate PrEP therapy right here. We partnered with a lab to take the blood test. We had the rapid HIV test to make sure they weren't HIV positive. And we came up with a whole infrastructure to launch this program. And of course, it launched the same month as COVID broke in 2020. And that was a whole other issue. So everything focused to that and away from this issue.
Do you think that'll be something that the state picks up and kind of does the same type of, you don't have to have a specific collaborative practice agreement to do that they expand that to other pharmacies in the state? Or
yes, that's what we're pushing for. The state loves our model. They've actually issued statements on it. They say this is the model of how we should be addressing the HIV crisis in New Jersey. And Governor Murphy had an HIV-free by 2025 initiative, but again, that was pre-COVID when all the resources and attention sort of switched. But yeah, there is New Jersey has a program where they fund community organizations called PrEP clinics, and these are typically run by community-based groups, nonprofits that go out into the community, and they go out and they try to recruit people who are at risk to try to initiate PrEP therapy. And I actually got to attend that. I'm a certified PrEP counselor, and in doing that, I learned about how difficult it is for these community organizations to get patients from acceptance through all these different steps that they have to take. Going to a lab, waiting for results, going to a doctor, waiting for an appointment, going to the pharmacy, and we pulled it all in-house, where the entire process would take one visit and in less than an hour. We actually got down to the point where we had teleprep available. So when we got done working the patient to the point that they were ready for their visit, we could have the visit immediately on a pad, and the patient walks out with their first prescription for PrEP in hand. And that was always the goal, because there's so many points where you can lose that patient. This model really helped, and the centralization of the data that the state was trying to collate. The PrEP centers, the PrEP clinics that the state was funding, the patients would go to a pharmacy and they'd sort of just disappear. They would lose contact with their PrEP guidance counselor, when we brought those two entities together in one collaborative unit, there's a lot of interaction between the medical side of it and the community organizational side of it. And if we see that a patient's coming up on their final refill of PrEP, we had the ability to tell the PrEP navigators, listen, you need to touch base with so-and-so. We've got to get their doctor's appointment before the end of the month. And that really improved outcome and the amount of patients that were remaining and refilling PrEP on a regular basis.
Was the telehealth doc, was that a local doctor or was it a state doctor?
It was a local doctor that happened to be in the PrEP space.
Okay.
And she really just specialized in this sort of thing. And again, we set this up when telehealth was, sort of never going anywhere. I don't like to say that there were a lot of positives during the pandemic, but what retail pharmacy, community pharmacy, independent pharmacy was able to demonstrate during that time, I look as one of the bright spots. And telehealth is also one of those. Telehealth was something everybody shied away from. But now that it's ubiquitous, everybody accepts telehealth. All the payers pay for telehealth now because the value of the technology was realized during the course of the COVID pandemic.
It seems like during the pandemic, you started up kind of a mobile immunization clinic, or did you start that up before the pandemic to kind of help promote the
vaccinations?
Yes.
Well, we started off with the idea of mobile immunization clinics because looking at the way pharmacists were able to do immunizations, the idea of bringing that to schools. And even schools where in Camden, we have a high undocumented immigrant population,
really,
who maybe aren't getting access to healthcare like they could. And the school will tell them, well, you're required to get your child these vaccines, and the parents are just, what do we do?
Right.
So our idea was to partner with the Camden School District and bring that ability to immunize the kids who were going into school who hadn't had their immunizations yet, or those who needed to be boosted, later on as they became teenagers. The offering of the HPV vaccine to those who were appropriate for it. But it was the idea of partnering with the school district and utilizing that access to the community to help decrease those barriers to getting immunized. And that was our original concept for the mobile immunization clinic. Now, of course, again, when COVID hit, it changed all of that.
Right.
But we had the infrastructure in place where we had already prepared for this, not for a COVID vaccine, but for other vaccines. So we were very prepared to pivot and convert that vaccination program directly to COVID-19 vaccinations.
So talk to us about the process. I mean, that's super, that you were able to work with the schools is just beyond impressive to me, because working with schools on things can be quite difficult trying to get anything accomplished. And so
tell us about your personal experiences now. we say public schools where our kids go to learn that adults don't make sense.
Yes.
Hey, I have three 14-year-olds, so I'm learning that I'm not nearly as intelligent as I once thought that I was.
Triplets.
You have triplets?
Yes,
Wow.
I do.
Wow. Okay.
That's impressive. No wonder.
That was your reaction when you found out. Yeah.
Yeah. So
are they all different? Are any identical?
Yeah, they're all three are different, and thank goodness for that. But I always said I wanted to be done having kids by age 37. I never expected to have 3 at age 37, but I guess I kept to my original life plan.
So how did they get along well? Do they not get along?
That's built-in best friend. But maybe. I imagine
they could be built-in competitors. So how's their relationship?
Believe it or not, they get along really well.
Yeah.
Sometimes a little too well, and they're very good at teaming up and completely disorienting me. So I have to try to keep the alliances separated and deal with them one-on-one.
Yeah, I have 2 brothers who are identical twins with each other, not with me. Mm-hmm. And they were like that. They were like, they had their friend, so they didn't really need other friends. Even so much that at a very young age, they developed their own language. So they initially had their own language between the 2 of them that nobody else understood.
I mean, you see lots of Instagram videos where twins are sitting there and they're having a conversation and it's a baby talk, but they know that they understand each other.
Yeah, it's
and I wonder if that's true with triplets.
Yeah.
Well, I haven't seen that, but what I can tell you is this: I have no idea what they're talking about just in general anymore.
Just in general, yeah.
To all of it seems like its own language. They say things I have no idea what they're talking about.
Yeah, that's a fun age. Marsha just had one turn 13.
Yes, and I have one that's going into her senior year in high school and then off to college.
Is it a mix of girls and boys?
It's 2 boys and a girl.
2 boys and a girl.
So yep. So we got the whole experience all in one shot.
Yeah, seems like a lot of joy. To be honest, I think it sounds fun. Makes me smile just thinking about it. Mm-hmm. It's a fun piece.
Back to your working with the schools and immunizations. Talk to me about that process. I mean, how getting to work with the schools, that's a hurdle I would love to hear about. And then number 2, I guess, talk to me about your process as far as, recording and capturing the patient data.
Yeah, is it weird with undocumented work with undocumented children? Can you report it to the state registry? Is it, is there more sensitivities there?
Well, believe it or not, most of the undocumented immigrants are covered by New Jersey Medicaid or the managed care organizations. Okay. So by and large, they tend to be insured.
Okay.
Even you can get the insurance without having to prove immigration status.
Right.
So the schools are usually very good at making sure the resources that are going to the students, or the resources that the students can avail themselves of, are realized. And that's one of the reasons, so much of what we do is this idea of forming partnerships with community-based groups. And the schools are one of the biggest ones, of course, because in the community, they're hands-on every day. They're seeing things that we don't see. But we understand that, in Camden, there's a huge access issue. For some reason, we have world-class health facilities in the city, but the residents still continue to lag in taking advantage of those services and even in public health outcomes themselves. So what we try to do is partner up what we can bring to the table with what the reach that these community organizations have into the community. So, for us, it's expanding our practice and our patient base. And for the community groups that are involved, they feel like they have a partner. It's like now they have a problem, they know who to go to help them solve it. So
are you working though with the individual school? So are you going to so-and-so elementary school? Or are you like going to the district and saying, hey, we're gonna do the solution for the district?
Well, part of what, it comes down to, you have to be able to make contact within the district. And there's a lot of confusions. The school board that I go to, do I go to the building principals?
Right.
Do I go to the superintendent?
Yep.
I'm active in our business is active in the Camden Schools Foundation, and we provide scholarships to kids who are on their way to college. So I'm sort of interwoven into the fabric of the school district just
Absolutely.
through my charitable work with the Camden Schools Foundation. So the conversations were a lot easier for me to have. But I think that's it's a good lesson for those pharmacists who are going out there and wondering, well, how do I integrate more fully into the community? And part of that is becoming involved in philanthropy locally. There's so much of a need. So many businesses like to say, well, let's send money here and send money there. And there's so much need many times in your own community that if you address that first, it's more of a direct connection. And I think it's a better use of your charitable contributions. But that is really what opened the door, because I'm in more settings where we're just having a conversation. And then when you can do that with the superintendent, they'll be like, oh, well, call this one, and we'll get it all set up and let us know what you want to do. That helps, as opposed to just making a cold call. Superintendents of especially urban districts are very, very busy, and you're not likely going to connect. So it's being involved as part of your community rather than just being a business that serves the community. That's something we've always believed in, and it's one of the hallmarks of why this business has been around for over 90 years. We
have a little bit this debate of, and I'm gonna shift out a little bit, then I'm gonna bring this back home, and we'll see where I'm going. But do we call ourselves community pharmacy, independent pharmacy? And we've tended drifted to saying more we're independent pharmacy because the chains have kind of adopted, we're a community pharmacy too, right? But when I hear you talking, I was like,
it falls more.
I was like, wow, he's a community pharmacist, pharmacy. Right? Where he's not just in the community, he's part of the community, and calling him an independent pharmacist doesn't describe this person I'm talking to right now. And that maybe we need to not shy away from it because the chains are trying to steal it. And because we do a lot of time, trying to convince pharmacists that if you're behind the counter all the time, you're going nowhere. You got to get out. You got to talk to public health. Guys like Eric Larson that we've talked to on here and stuff like that, who when he bought a pharmacy, he made sure that he funded it in such a way that he wasn't behind the, get enough funds when you open that pharmacy that you got enough money stored up in the beginning not to start off behind the counter. A lot of people say, well, I'll start off behind the counter till I grow my business. Well, you're growing your business not behind the counter, right? So
yeah, it's knocking on the doors and talking to like school boards and he's knocking on doors and talking to nursing homes. And like we were there when he got his first batch of COVID vaccines in, and he called one of his pharmacies up and goes, hey, I've got 50 shots. I can be there tomorrow.
Yeah, so here we go. So I'm not an independent pharmacy, not a community pharmacist. I'm in the community pharmacist. Yeah.
I like being the community pharmacist. I typically refer to myself, I always say an independent community pharmacist. But what I always recommend to anyone who's in the independent community pharmacy space, it goes back to what Cal Knowlton told me many years ago. You got to get away from that. We're never going to outcompete the chains. You just aren't. They've got much greater resources, both financially and, they can do, if you're going to fight them over Motrin and ibuprofen, you're going to be out of business because that's not where the future of pharmacy is. And one of the reasons that, I don't want to say that it pleases me to see CVS closing 900 stores and all. In many ways, the chains are themselves becoming victims of their own economic model. the PBM model of low reimbursements. That's all that they depend on. And as they continue to shave those margins down, that also impacts their brick and mortar stores. And, they're not able to keep themselves going on just dispensing prescriptions, which is why we go far beyond that. And we really bring it into services. We really look at, okay, what does, my individual community need? And, we learned how valuable the community pharmacy is during the COVID-19 pandemic. I mean, I could tell you that in Camden, we were much like any other urban center that was post-World War II. It was a mostly European immigrant population that we had. Every little neighborhood in Camden, each one of them had one, if not two, independent pharmacies that served that neighborhood. Because everybody knew that the Irish and the Italians and the Polish and the Hispanics, they were all different back then. And there was different culture, different language, different social mores, and their independent pharmacy knew how to speak to them in a way that made them comfortable.
Yep.
As most of the independent pharmacies have been driven out of the urban environment, unless new graduates are willing to jump in and assume or do something like what I do and be an independent pharmacy owner, we're experiencing pharmacy deserts. And, we face that here in Camden. We have a couple chain pharmacies on the outskirts of the city, but we're a city of 85,000 residents, and it's a very diverse city. People oftentimes, and it always drives me crazy, they'll refer to Camden or any urban area sort of generically, well, it's a community of color. That doesn't recognize the vast diversity when you're speaking about communities of color. African American is not the same as Dominican and Haitian, right, and Caribbean, and Puerto Rican is not the same as Mexican or Brazilian or Ecuadorian. And we even have, it's less so now, but we even had an Asian population that was largely Vietnamese, and Asian populations are also different. And you had very few of the places like me that knew how to work with their community, talk to their community members, and get them over this idea of vaccine hesitation. Especially our community is largely African American, and as we all know, there's been a sort of untrustworthy past when it comes to vaccinations, and many of my community, they lived through that. Mm-hmm. And they came in genuinely concerned. They're hearing this is what they need to do, but they need to hear it from someone that they're talking to almost as someone they know, someone they trust.
Right. Yeah.
And you go over the pros and cons with it. I won't get into all that because we all know what they are now of getting the vaccine, and people made a decision. And what we did was we never really forced this on everybody, but what we did was, believe it or not, I actually found in our area vaccine frustration, that inability to get access to a vaccine was a bigger concern than the vaccine hesitancy.
Right.
So much of the public relation effort that you saw on TV and on radio and everything had sort of acclimated everyone to this idea that maybe they should get the vaccine. But in Camden, especially because we have all these healthcare campuses, everyone from the suburbs comes in, they consume all the resources and lock all the community residents out. They just can't get access. So what we did was, we not only tried to get the community over this idea of, the vaccination's untrustworthy and get them over all the political rhetoric of it, but I said, we guarantee that if you're a Camden resident, you will come in and get a vaccine. We don't have appointments. We didn't do pre-registrations and lines.
Mm-hmm.
That was the
biggest,
not your demographic.
Yeah, that was the biggest struggle in the beginning when the vaccine for COVID came out was you had to fall in a certain age demographic. You could only go to chains or to the county, and you had to register, and you had to fill out all these extra forms and basically get in line. And when I found that I was able to go to my community pharmacy, like I was texting daily. I was like, do you have Pfizer in yet. And as soon as she told me she had Pfizer, she texted me and said, great. And I was like, he'll be there tomorrow.
So go ahead. So you didn't do appointments because your demographic doesn't support it, right? And so you just staffed to handle the line.
Initially, we did have appointments, but nobody used them.
Right.
And the idea it was to screen out people from outside of Camden, so I could always prioritize the Camden residents first. But what we did was we staffed up to the point. We brought on 3 nurses in addition to the pharmacy staff that we had. We had a completely converted area. It's what you see behind me is the COVID clinic. And our infrastructure supported our ability we could do 5 vaccinations at a time with social distancing. And we were probably able to handle up to 250 vaccinations daily.
Wow.
And
that was all. That 250 daily was just in the pharmacy. That wasn't doing any mobile.
Right. Then we went into the schools and we did school clinics where we would send our staff out there. We did a lot of clinics like that. We offer clinics in churches. Anywhere where we saw that there was an underserved population that either maybe couldn't get as far as where we were, we would go out to them. But we did a lot of work with the schools and doing vaccination for them. And it's sort of in August of last year, as the vaccinations were sort of humming along, we figured, what? Testing when the fall comes around is going to be where the next big thing is. And we were ready for testing before people even really started getting into the testing. But when we got that spike in December and January, we were one of the only facilities that still had testing available because we got so far out in front of it, and our priority with the lab that we partnered with, we were like number 1. So if they had any supplies, they came to us first. And in the height of that mid-December through late January, we were doing 125 vaccinations in pharmacy a day, plus 250 tests. And we even went a step further. And when monoclonal antibodies became available, we were able to get priority, a facility priority to offer monoclonal antibodies, which was really taking off until they pulled the plug on it. But again, we aggressively went out and we noticed the need within our community, and we set about to providing a solution, and we're the solution.
What about other vaccinations during that time? Did you like flu and shingles, and were you weaving those in together, or did those kind of like get ignored during that time?
I'm more of a soft sell on this. People were coming in and they were they were nervous enough about the COVID vaccine. So I didn't want to overwhelm them or risk them saying, I don't want to do this by saying, well, you're eligible for the shingles vaccine, you're eligible for that. We sort of waited and we used the data that we gathered during our vaccination, all the people that came in for vaccinations, and we use that as more of a soft marketing. You are a senior citizen. Here are some vaccinations you may want to consider. I've never really bought into the idea that we should. I know that the chain pharmacies are real famous for this. My ex-wife is a CVS pharmacist. She's got quotas. They've got to go out there and they've got to actively push this idea of getting flu vaccines. I don't think that's appropriate professionally. And there's always a balance when you're in retail pharmacy about revenue is important, but we're also professionals, and that matters too. And that's my style. I never felt comfortable going and actively, taking people and cold calling them, so to speak, and saying,
right,
you need this vaccine. And did you ever think of getting that vaccine? It's just not really our style.
So with as active as you are in the school board, and do you see ever a time putting, COVID test kits inside the school? So when a child comes into the school nurse, they know instantly, okay, great, you've had these symptoms, let's swab your nose and put a mask on you?
It's an interesting thing. School nurses are district employees, and as district employees, they belong to a union.
Right.
And the idea that they would do COVID testing, it has to be negotiated through their union, and the district doesn't even want to get involved in it. So your solution is a common sense solution, and it makes 100% good sense and good medicine. Unfortunately, that's not the way it works, at least in this area.
I mean, I'm just thinking because, like, when my son got COVID, my husband picked him up. They thought, oh, it might be just a strep throat or a cold or something. And then he picks him up. Neither one of them wore masks in the car. And then he starts to go, my throat feels weird. And then we get him COVID tested. And then the next day, my husband's like, now my throat's hurting.
Yeah. Like they should have tested him at the school.
Yeah, if they would have tested him at the school, then they would have known, hey, put a mask on. Dad, you need to put a mask on.
We do work with Camden School District, among others, where we go in and we handle their regular staff and student testing, typically as part of their COVID mitigation plans. They require that a sample of kids are tested almost every day. So we already handle that, but I think that what happens is the school right now, will call, they'll tell the patients, go down to Bell Pharmacy and get a test. That's pretty much how they handle it. So we're accomplishing the same thing. I don't think it's as convenient. I think that your solution is better, but then again.
There were some schools here that after the winter break, they were requiring you to bring do a COVID test before you came back to school.
Yeah, there are all kinds of different stuff all over the country, different ways. So tell us about the Independent Pharmacy Alliance.
Yes. Yeah,
the Independent Pharmacy Alliance. It's a sort of a trade group, for lack of a better term, that was it was community pharmacist based. Okay. And there's really two of them in New Jersey that are the big organizations. It's Garden State Pharmacy Owners and Independent Pharmacy Alliance. Over the years, being in pharmacy so long, initially I was in Garden State Pharmacy Owners, and then when Independent Pharmacy Alliance started, I just joined them also. The two now kind of work together, even though they have their own individual rosters. And I don't know if I've mentioned this. I've spent 20 years as an elected official in my township, and I've been retired of that since 2018. And I got involved with the Independent Pharmacy Alliance because it allows me to put a lot of the political, skills and knowledge that I accumulated over all these years to work in advocacy for community pharmacy. And much of what we do, I mean, there's some things that with PBM reform and such that that's one part of it. But a lot of it is about using what we've done, what independent community pharmacy has demonstrated in the pandemic, using this as here's what else you could be allowing us to do. And a lot of these changes, just to go backwards, we can administer vaccines in certain situations, but only by executive order. And it's only in response to the pandemic. So a lot of those emergency authorities that we were granted during the pandemic, we're working to have made permanent. They've already been demonstrated, but it requires a legislative change. We're working on initiatives that allow pharmacists, piggybacking on what we've done, to be able to issue and administer PrEP, whether it's the Truvada or Descovy, or now they've got the injectable Cabenuva, absent a doctor's prescription and under the authority of the Attorney General and the State Department of Health. Pharmacist prescription of oral contraceptives, pharmacists being authorized to administer a lot of the injectable drugs for mental health. Mental health patients were severely impacted by the COVID pandemic because their ability to get those injections that they used to receive monthly was tremendously inhibited. I mean, if they could get into their doctor's office, and there was so much around it. Well, in our situation, we already had the infrastructure to go and do these administrations in home. Doctors' offices just don't have that capability. So, the ability of having that access. So much of the legislative work we do is about not letting everyone forget how well and all the praises that everyone gave independent community pharmacy. But okay, hey, we showed you we could do it. If we move the needle here, look at all these other things we can do, and convincing legislators that, as I know in politics, you have to identify a problem and you have to identify a solution, and that solution is going to make constituents happy. So I focus on those three things with our legislators, and the Governor Murphy's administration has been very supportive of us in this endeavor, and we've got a lot of exciting things that are happening in Trenton.
So that's the Independent Pharmacy Alliance is obviously independence is in the name. The Garden State, is that independence as well?
Right, they're independent pharmacies also. That was more of an ownership group, although Independent Pharmacy Alliances too. They act as buying groups. They have wholesalers and contracts, but they also have. I'm in both of those groups. I'm in a completely different buying group, but I'm active in those groups for the promotion of independent pharmacy in general. So I work with them in advocacy and in raising the profile of groups like New Jersey Pharmacists Association, where I'm the vice president this year. It's more about the profession, expanding the profession of pharmacy versus an economic model, but they offer that also.
And you also have a role in the New Jersey Pharmacy Association, which is all the pharmacies. You seem to me that guy who steps forward and everybody else steps back, right?
An active in the school board.
Either step forward or everybody step backwards.
Yeah, VP, president.
Sometimes there's a moment. And if you don't act in that moment, it passes and the window closes. And there was, what independent retail community pharmacy did for this vaccination effort was phenomenal. It was failing when the chains were administering it. It was failing when the county departments of health and the government were doing it. It wasn't until they allowed independent pharmacy to get off the sidelines did you see everything. All of a sudden people started getting vaccinations, and there wasn't lines for days. And we really demonstrated that, we do more than just count pills. And but that, everything, time moves on and perceptions can change. And before that happened, I felt we had to drive our organizations. Now, this is what we've always wanted for all these years. Everybody's been dragging their feet on it. We've got to push, and we have to push hard, and we have to push effectively, and we have to push efficiently. And being a politician, I know how to speak to politicians because I know what would work with me. And that's really what I bring to the groups to help advance our profession.
You seeing a lot of success?
We're seeing success now in the last year that we've not been able to realize in the last 7 to 10. That's how. But again, it just takes that push. You have to have a perfect combination of circumstances to be able to realize the sorts of changes that we're asking for. After doing what we did with the COVID vaccines, it's not as easy for the prescribers, whether it's the Board of Medical Examiners or whoever represents the nurse practitioners, to say, well, wait a minute, that's our playpen, pharmacists, you got to stay out of that. They can't give that reason. Normally they'd say we weren't qualified. Well, now we are.
Right, you can't say that. Right, you did.
Right. And like I used the Narcan. We can do Narcan. Well, why can't we do PrEP? Why can't we do contraceptives? Aren't those all preventatives? If you're giving us this ability to prescribe preventatives, why not let us go all the way with it? Especially if we're addressing an issue that is still at a very crisis level in New Jersey, which is HIV.
How's the I saw where New York, this latest little COVID surge was kind of plateauing. What are you guys seeing in New Jersey right now?
Well, I think it's all largely a matter of testing. The more people you test, obviously, the more positive tests you're going to see. A lot of people, they just don't. They feel a little bit sick. They just don't bother. Well, now everyone goes and gets a COVID test.
Right.
So whereas maybe before they wouldn't have even thought anything about it, they would have taken some Sudafed and that would have been the end of it. Now they actually get a test. So I think we're seeing more cases, but also what we're not seeing is a spike in hospitalizations and deaths, and that's a real positive trend. You're never going to. People talk about beating COVID. You're not going to beat COVID. Nobody's ever beat any of these viruses. So, what you have to do is you have to, virus, I have my own opinions about whether it came from nature or a lab. I tend to think it's synthesized, but that's because it's not reacting normally. Normally, you get a spike in spread, but the symptoms are less. The virus will mutate and it'll change, but it's more to keep itself going.
Right.
And it becomes weaker and weaker, and then it just becomes the common cold, which, the common cold is a COVID virus or coronavirus. So I think what you're seeing is this virus is getting to that point. It's taken it more time, but that's because there seem to be unique qualities to the way this virus mutated that we don't typically see in normal viral transmissions.
Mm-hmm. Okay, so you said you started in your grandfather's pharmacy when you were 14.
Mm-hmm.
You have 3 14-year-olds. Is there any interest? Are they helping? Are they?
Well, it's hard to say. What I do is not easy. And it's not for everybody. And, that's what I often say. In fact, my stepdaughter, Amanda, she just graduated last year, and, she wanted to give this, what I do a go. And
of
you
course,
can tell she bit off a little more than she could chew when it comes to it.
And of course, pharmacy is a lot different than when you were 14.
Mm-hmm. Yeah. I mean, listen, if you have an entrepreneurial bent,
Mm-hmm.
and you have a passion for your profession, the two of those areas can really come together, and you can be successful as an independent pharmacist.
Mm-hmm.
There's a business side to this, and if you're a clinician and don't have the business side, you're not going to make it. There's a combination of the business of pharmacy and the practice of pharmacy that just the synergy of the two is something that over the years, and I've been doing this since in 1992 when I graduated. Over the years, I've just developed an eye for where pharmacy can go, and if I can see it, then I know I can get to it and make it successful. We're offering pharmacogenomic testing now. Again, another technology that I learned about largely from Cal Knowlton,
Mm-hmm.
that basically is only done to people with patients that are in nursing homes. We're bringing pharmacogenomic testing to our whole population now by offering it through the pharmacy.
Is that cash though? That seems a bit, to me, I was hearing that they've had a lot of problems getting that paid for, and you're in kind of
getting it paid for,
Medicaid.
and it had to be doctor prescribed in some states.
Yeah, so
I thought.
Yep,
So
it
how?
still is.
Okay.
We've come up with a model. We've formed a partnership with the national lab. They have their own prescribers that we have the visit through telehealth. And we also have a software program where we can tell if a patient's insurance will or won't cover it. Medicare covers it with no copay, and really that's the demographic that really benefits from this. And especially with Medicare and outcomes and trying to prevent readmissions, there's so much problem with polypharmacy and patients getting medications that just don't match what their body is going to do. This idea of individualization is really the next thing, and I think over the next few years you're really going to see an explosion in this pharmacogenomics. But what we're doing is, like we always do, is we're taking something that's available to the few, and we're finding a way to make it available to everyone. And again, it's one of those synergies of practice and business. Something else that it's sort of flown under the radar is cannabis dispensaries. We're actually opening, hopefully soon, the first pharmacy-based cannabis dispensary in the nation. Now, cannabis dispensaries, medical and otherwise, the medical ones all have to have a pharmacist as an employee. We're making the pharmacist the owner of the dispensary. And it's a model that really appeals to prescribers. So many prescribers want to prescribe cannabis to patients, especially to get them away from opiates. They're wary about the idea of giving them a card and sending them off to a head shop. So
right.
What we're doing is we're reestablishing that pharmacist-patient prescriber dynamic and giving prescribers who want to prescribe the option to work with a pharmacist in a patient treatment plan that utilizes cannabis. We're initiating pharmacogenomic testing for patients who want to use cannabis medically. There's tests that can determine what their bodies will respond to most appropriately with regard to, like, is it a sativa or is it a lot of the pharmacodynamics of cannabis are so similar to what we do with regular medications, and it's completely underutilized. So what we're doing is, we're giving what I always like to say, the shy cannabis consumer, maybe someone who really wants to try it but doesn't want to go to a dispensary. Mm-hmm. They're not coming to a dispensary; they're coming to Bell Pharmacy, and
that's amazing.
Right? And they're getting our model is more of a spa and wellness approach. We call it Camden Apothecary at Bell Pharmacy, but it's like you would go to Sephora and get a makeup consultation. That's one of the services that we're offering. So what we're doing, we're really, by the way, the cannabis companies do not like this idea whatsoever. They don't want to be in the pharmacy business, and they don't want pharmacies in the cannabis business. So we're taking, it's a completely groundbreaking concept, but it's one that I personally have been working on this since 2017. But yeah, it's such an exciting time. I mean, I hear so many people lament the death of the independent pharmacy and the professions going. I feel bad. I lament what's going. I should say, they should be lamenting and crying for the chain pharmacies. They're the ones that are going to get driven out by Amazon. They're the Borders and the Barnes and Noble of the 2000s that everybody thought
I said that in a speech. Yep.
People want an experience. They want a relationship. They want different. And that's why I always say, do not compete with the chains. You won't win. You have to offer something that's not them. And people want that because they've just become the chain. It's like going to a mall anymore. And people want a different experience. Mm-hmm. They want the independent to succeed.
Mm-hmm. And what a great close. That was awesome. I think we're out of time. That was amazing.
Thank you so much for joining us today, Tony.
Appreciate it. And
it was really great to meet you and get to learn about all that you're involved in and what you've achieved.
Yeah, more than great. It was inspiring. And it's really cool.
Absolutely.
Mm-hmm.
I just, wish every day we can make more of you, because that's what we need. So
I'll tell you, my goal is to get that. I always say my competition isn't the chain. My biggest fear is somebody like me that's younger opens up next to me and does the same thing. But in the advancement of the profession, I would agree. We need so many more motivated professionals to take this on and I try to let the passion that I have inspire them.
Yeah. I'm always saying that there's not enough on the motivated side.
All right. Well, thank you. It's great talking to you.
Thanks, guys. Have me back anytime. And
all right.
Even if you don't want to do a podcast, I'm always, as you can see, very willing to talk.
Yeah. All right.
Thank you so much, Tony.
All right.
Bye-bye.
Thanks. Have a good day.
Right. Bye-bye.
Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode,
please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.